Veterinary Eye Talk, let's go!
Good morning, everyone, or good afternoon if you're in the States. It's, in fact, Super Bowl Monday. No, Super Bowl Sunday is my understanding over there. It's Monday in Australia, so I guess it's Super Bowl Monday over here. How you going, Ben? You going to a Super Bowl party or first one over there?
I am indeed. So, yeah, I'm primed. I'm ready. Going to a mate's place today for Super Bowl. I live across the road from a casino in Las Vegas. So, walked across this morning and put a little bit of money on the Patriots, who I know literally nothing about other than just growing up, they were all the rage. So, let the good times roll. Go Pats, apparently. So, anyway, that's what I'm doing, mate. What are you doing?
I'm working today, but I'm sure the Super Bowl will make it on the TV. So I guess you've given me a team to bat for now as well. Who are they playing against? Is the Hawks or something? The Seahawks?
Yeah, the Seahawks, mate. The Seahawks. That's the thing. I mean, Australia's full of people who think they know a lot about it. Like, if you know the quarterback and the running back's name, apparently you're a super fan by Australian standards. So there'll be someone, I'm sure, at your work today who knows two players and thinks that they're an absolute savant. So let me know who that is.
I think we both already know who that is, but yeah. Actually, the Seahawks, that's the Seattle team. So Dr. Sean Collins from Texas is I know he's a mad Seahawks fan. So if he listens to this, I think he's going to have words with you in the future for backing the wrong horse, so to speak.
We'll see.
Yeah. Do you know who's favored to win? Is it the
Seahawks, mate? So yeah, it's just my unrelenting desire to back the underdog. Hence why in the NRL I love the Penrith Panthers. Even though they won 4 years in a row, they're still doing it tough for the boys out west.
Mr. Ben Reynolds, everybody. Penrith. Panthers. My sister actually went through a Penrith Panthers phase as well, and she grew up in Paddington, so we used to call them the Paddington Panthers. Which, I mean, you only get that reference if you're from Sydney. So I'll leave it there. All right, mate. What are we talking about today?
So today we are thinking we will talk about something we see a lot in clinical practice, highly relevant. We'll talk on practical tools. We'll talk on, the diagnoses, treatment. But we are, of course, talking about indolent ulcers in dogs. Goes by a couple of names. So the new, it's not that new. It's about 20 years old now. But the most correct name for it is a SCED, an SCCED, a superficial chronic corneal epithelial defect. And yeah, exciting topic, Paulie. Do you want to run us through a bit about what that is?
Yeah, sure. So I guess for those of you out there who haven't heard of an indolent ulcer before, I don't know I actually, now thinking about it, if there even is an official definition of an indolent ulcer, then it's escaped me. But effectively, we're talking about a non-healing ulcer where the underlying cause of the ulcer can't be determined. So there's no, or there is not present. So there's no entropy in driving it. There's no foreign body. There's no infection. And we have all this redundant epithelium, so the outer layer, that's unable to stick down. And so I always say to general practitioners, not all non-healing ulcers are indolent. So, you've got to get that, in your head. But all indolent ulcers, I guess, are non-healing. And in terms of the mechanism of why they don't heal, I mean, I always give it a sort of really basic description to the client, and that is we have the formation of this sort of slippery membrane underneath the epithelium, or maybe not formation, maybe it's already there, is my understanding. And I liken it to, a surface on a wall where the paint's been stripped and you've got this slippery surface underneath, and you keep painting new coats of paint on top of it, and it keeps just peeling back away. And that's my really, really basic sort of level description that I'm sure has got a lot of people rolling over. And you know,
I mean,
annoyed.
mate,
I'm not talking
as
about.
as someone who I'm not very handy, like mechanically, Henna, my partner, does all the heavy lifting of constructing and stuff around the house. But I also try and give a really like stereotypically blokey description as well. I'm like, you know, it's like trying to put tiles down without grout. You know, you got these slippery tiles on the top, which is the epithelium, but it just can't stick down because there's no grout there to stick it to. So yeah, it's funny that we both have analogies that do not reflect at all the lives that we lead outside of the clinic.
Not even a little bit. The best thing for me actually was one time I was actually talking to a client about this, and the son of the client was in the room, and he turned around and he just said, "So you're telling me, bro, he just needs a base coat?" And I was like, "Yeah, kind of, I guess."
Yeah. Oh, so good.
Now,
So good.
let's talk about you know, sort of we'll start. We've got to get better at running down the flow. So signalment. So when are we seeing indolent ulcers? Oh, although Ben, if you want to jump in and give a much better definition, I'm sure you can. If you've got one if you've got one in the back of your mind, compared to what I just get butchered, but I can't really think of it. You know, I have to Google.
So essentially, like by strict definition, like for something, so normally an ulcer should heal uneventfully in 3 to 5 days. Anything longer than that's non-healing. As you touched on, Paul, not all non-healing ulcers are indolent. The true definition, as you know as well, but you know, it's strictly a histologic diagnosis. But as most things with ophthalmology, you can clinically diagnose them. On histology, basically, there's a formation of this anterior hyalinized acellular zone, which, you know, it looks like hyaline, like it looks like cartilage. It's not cartilage, but it looks like that. And you know, as alluding to Paul, that's like the lack of the buff. So there's nothing for our little epithelium to stick onto in the stroma. We got this. I'd sort of say it's like a dysplastic, but it's not, because obviously the dog's not born with it. But it's like a degenerative change of the anterior stroma, where they form this little zone and they can't. The little epithelium can't stick down adequately. I'm sure there's a paper with a perfect definition, and we possibly should have pulled up Gillette and read the textbook definition, but essentially that's the crux of it.
Yeah, and on that, I think it's important we talk about just briefly what the actual, you know, what the appropriate healing time for a non-complicated ulcer is. And I've actually read varying from 5 to 7 days. I've even read some places, I think, where they say 3 days, which is probably a bit optimistic, but I think anything over that sort of 5 to 7 day mark, once you are hitting that point, if the ulcer is still there, and this just comes down to general corneal ulcer sort of understanding, then you move from that categorization of a simple ulcer or a non-complicated ulcer over into a complicated ulcer. And so that's just an important thing to touch on. I think the next thing we need to talk about is signalment. So what are your common sort of, I guess, your common players in terms of dogs that are coming in with an indolent ulcer and common age demographics?
Yeah, so we see these really commonly in breeds that come in for lots of different ocular disease as well, but the classics are like boxers. So this used to be called boxer ulcers when boxers were a really common pet breed. That's sort of reduced a little bit, but in contemporary practice, like French bulldogs, British bulldogs, in Australia where they're common Staffordshire bull terriers, over in the US where they're common like things like pit bull terriers, I'm seeing them in like Dogo Argentinos. You can see them in any breed though. Like, I mean, I've seen a bunch in golden retrievers, seen a bunch in, that's well reported in like Welsh Pembroke Corgis. There's all sorts of breeds that can get it. And, you know, I wouldn't discriminate based on breed, but they're certainly the most common we see. But, you know, I've seen them in Chihuahuas, I've seen them in Great Danes. So literally anything on that spectrum can get them. But yeah, most commonly, I think I always say, and I'd be curious as well, your experience, Paul, but most commonly, I think the breeds that have like short, bristly coats, like you think of the coat of a boxer, a British Bulldog or French Bulldog, I'm hard pressed to think of a breed with that type of coat that doesn't get them commonly. And I don't,
I've
I
never thought about that. Right, okay.
Yeah. I don't think it's like, you know, I'm not saying there's a common gene between short, bristly coats and indolent ulcers, but it's just, if you can think of a dog breed with a short, bristly coat, I think it's probably on the list of most frequently gets indolent ulcers.
Yeah, now that you've said that, I can't think. Yeah, I think, yeah, it's pretty fair. I think the other thing that's important, you know, in terms of signalment is generally we see these in sort of older dogs, so average age, you know, sort of like 7 to 9. There is an exception though, and I believe there's a paper that came out that described this, but it's certainly something I see clinically, and I do see in some younger dogs, in some certain breeds, younger dogs getting this type of ulcer, and in Sydney, the classic is the French Bulldog. Is that something you've appreciated over in the States as well?
Yeah, absolutely. Absolutely.
I mean, when working these up, if they, you know, and we'll talk about that next, but the signalment is a big, I guess, helper for you in terms of getting to your diagnosis. I am always, you know, much more, I suppose, suspicious of a different cause when I see a dog that's, you know, around, you know, that younger age. But if you rule out everything else and you've got something like a French Bulldog and, you know, the sort of shoe fits, so to speak, you know, I've definitely seen them in much younger French Bulldogs, you know, probably around the 3 to 4 years of age. And it's less common, but it's definitely something I've seen.
No, I agree.
Compared to,
yeah, I agree with you. I think they're definitely going to be on the younger side. I guess just touching on papers and stuff and cause. Not that this changes anything clinically, but you know, Gilger's team a couple of years ago now, probably 2020, 2021, found a gene in boxes, the NOG or NOG gene implicated. So we don't know if that's the gene in all breeds, but certainly in boxes, we know that that's the implicated gene that might impact how well the corneal epithelium regenerates and predisposes them to this.
There you go. All right, diagnosis, Ben. What are you doing to diagnose these, and what can our referring vets and I guess other residents and interns and everything do to help them get to this diagnosis?
So rule out everything else. You got a non-healing ulcer. You're like, all right, why is this not healing? Again, we got normally older brachycephalic breeds. So there's a whole bunch of stuff they can also get that prevents this. But if you do a thorough eye exam, you'll rule those out. So like, you know, dry eye, is there a lack of tear production leading to this ulcer to not heal? Is there distichia? Is there an ectopic cilia? Is there underlying entropion? All the things that, you know, you would be doing anyway, suspicious of an indolent ulcer, a non-healing ulcer, you want to rule out causes. Is there adequate corneal sensation? You know, you want to make sure that the dog can blink adequately. There's not like facial nerve paralysis or something. If everything else is looking normal and you just have this superficial ulcer that's not healing, they can be hallmarked by a classic appearance with a loose epithelial lip. So when you put fluorescent on, you get some fluorescent that runs underneath the adjacent epithelium, where again, that the tiles don't have grout, so they can't stick down and anchor and keep the fluorescent out from running underneath. But yeah, if you see all of those things, you'll be pretty suspicious. What I do to confirm it, which, you know, is a described treatment without jumping the gun too far, so we'll touch on that. But, you know, I apply some local anesthetic and I'll touch the edges of the ulcer. And basically, if I can peel off the healthy adjacent cells, which you should not be able to do, then that's a home run diagnosis. It's kind of analogous to if you had a cut, as I described to clients, if you've got a cut on your skin, you shouldn't just be able to rub the adjacent skin and peel off your epithelium. That's really abnormal. So if you can do that onto your cornea, there's obviously something defective there. Something's not working right, and, you know, we'd be really suspicious of this. Is there anything you do differently or you'd want to add to that, Paulie?
No, I think that's That's absolutely spot on. That's exactly what I do. I mean, when you see, and I always, and we'll get in more into treatment. The challenge with these ulcers is not so much. I mean, they can be frustrating to treat, but it's actually, in terms of when we talk about, taking the leap of faith to doing a procedure on them, the big thing is I would generally say that a lot of the procedures that we do in consult, are not technically all that challenging once you've done a few of them, but it's a matter of being certain of your diagnosis. And, it can be time. It can take time and seeing a fair number of them before you can sort of, get there. The other thing I would say is if you've got a non-healing ulcer in, a 7 or 8 year old boxer, for example, that should also sort of push your index of suspicion up, but you can't rely solely on that. You know what I mean? Like I've certainly been caught up in the breeds before where I've then found that, an ectopic or a distichia, and then whether or not it's, that caused the ulcer that's now non-healing or that's the actual cause, like that's something that we don't get into. But I think everything you said is spot on. Yeah.
I guess the other thing to touch on as well is the absence of infection or the absence of keratomalacia. So any ulcer, if you're missing that epithelium, is susceptible to becoming infected, and occasionally non-healing ulcers present infected. I had one earlier this week, for example, and that makes treatment a little bit harder as well. And yeah, to your point, Paul, like, the easy thing is treating them. The hard thing is knowing when it's appropriate. And I guess the caveats in, even if you've got a truly indolent ulcer, when to do the next step, which we'll touch on.
Yeah. So in terms of, let's say we've got a case, we've diagnosed a non-healing ulcer, and now we're talking to the client, what are we doing in terms of treatment? I guess I'll jump in and say, I divide the treatment options into basically 3 options. There is, applying a cotton tip applicator or a cotton tip debridement, as Ben said earlier. That is an actual treatment, and, debriding that epithelium away. As far as I'm aware, that carries a success rate of about 50-50 in terms of healing. The next treatment option I sort of group together, even though they are different procedures, but when I talk to people about them, and that is performing what we call a linear or grid keratotomy. So taking a needle and basically doing a little crosshatch pattern on the cornea. And that's sort of like, going back to Ben's grout analogy from before, you do actually sort of do a bit of a crosshatch before you start the tile down. So that's somewhat perfect. As someone who's tiled their bathrooms, their kitchens splashback before, I can tell you that from experience. And then the other option that's, sort of I put mentally in the same sort of category as that is a diamond burr debridement. And that's effectively, the best example or the best analogy I could give is that's like sanding the wall before painting over it. And then finally, the third option, which I guess is somewhat controversial as to whether or not this should be an option. At times I've heard mixed opinions about this, but is doing actually what we call a keratectomy. And that's, a referral option where under an operating microscope, you cut out the ulcer. Anything else you can think of, Ben? Am I missing anything?
I think they're definitely, you're covering 99.9% of what contemporary ophthalmologists practice. Just a throw out to what's out there in recent stuff. I tried my hands at a bunch of these, and personally, I didn't have greater success than just a diamond burr alone. So I stopped offering it. But there was a recent paper by our colleagues in Montreal, by Boutin and Franck Olivier, who describe a really, really high success rate by using essentially a cotton tip debridement and then debriding with a scalpel blade and then doing a grid keratotomy. And so they reported higher success rates doing that. And I tried my hand at it probably on 10 cases. And yeah, it wasn't inferior to, in my hands, to doing a diamond burr alone, but I was getting about the same success rate. And holding a scalpel blade
Yeah.
next to a conscious patient's eye made me sufficiently nervous to, in the absence of superior results, I stopped offering that.
Yeah. Yeah. There are a couple of other, I guess, variations on grid keratotomies. Like I know people do sort of like a punk type technique as well. There was a paper that I read about sort of corneal welding, they called it, where they basically
The thermal
cauterize.
keratoplasty. Yeah.
Yeah, which I've never done any of those. I mean, I
No,
can,
nor have I.
yeah, the success rates are either often, around the same as what's already really well established, or not much better. Has been my experience, and yeah, and I just think keep it simple. You know what I mean? The grid keratotomy and the diamond burr have been around for a very, very long time, and from an ease of use perspective and a safety perspective, they're the ones that you could probably jump on YouTube and find some really good videos like describing how to do them, for example. In terms of success rate, a couple of different papers out there, particularly with respect to the grid keratotomy and the diamond burr, but I often quote around the sort of 85% mark, sort of the sweet spot, sort of cut the papers in the middle. The keratectomy, our colleague, or ex-colleague, Dr. William Irving, actually published a paper that Ben and I were both fortunate enough to be involved in, looking at keratectomy, and that success rate is actually substantially higher. You're looking at near the 100% success mark. And it makes a lot of sense because when we talk about, performing the diamond burr, for example, there was a paper that came out a few years ago. Forgive me, I can't remember the author, but they looked at effectively how deep the burr tip could get into that hilum membrane, and what they found is that I won't bore you with the measurements for the microns, but the burr will not get deep enough effectively in order to completely remove that membrane. Whereas if you surgically remove the membrane, like you cut the membrane out, and we're talking the membrane out from memory, it's about 5 microns thick, so it's tiny. And I guess with the grid keratotomy, you're not even trying to remove the membrane, you're trying to crosshatch it in order to basically create a structure for the new cells to sort of grip onto. Anything you'd want to add to that, Ben?
No, not at all, man. I think you covered that well. I'm just rapidly firing through my paper database to find the name of the author so we can give a shout out, but unfortunately I'm having a hard time finding it, but I'm familiar with the paper as well.
For some reason I feel like maybe it was Grady Foote, but I can't remember. Sorry if you're listening and that's your paper, I apologize.
Oh, hold on. I might have it. Bear with me 1 second. Yes, it was Dawson et al. From UC, like from University of London, from the looks of things. But yeah, from our colleagues in the UK.
Oh, great. There you go. So in terms of aftercare and I guess comparing, the conversation that I have with the owners when they come in, we're talking about options. In terms of aftercare, the aftercare is largely the same for all 3 techniques. The only difference I would say is that there is a little bit of a faster healing time reported with the keratectomy, but we're talking 10 days instead of 14. So I always basically say to clients, look, it's a much for much in terms of aftercare. This comes down to a few things. It's one, if they've presented and they've already had several diamond burr debridements and they're really over it, then they might say, okay, well, I just want to go to the higher success rate. There might be an anesthetic reason there might be a patient reason to anesthetize or not anesthetize the dog. So, for example, cases I can think of where I felt like the argument to completely anesthetize the dog was a bit more sound was let's say if you have a really, I won't say aggressive, but I'll say shy dog that's not great at the vet. I've had one of those with bilateral indolent ulcers and would require heavy sedation in order to, perform the diamond burr. And after speaking to the owner, I was basically like, look, we got 85% chance healing for each of these if we sedate and diamond burr. If we have to effectively, heavily sedate your dog anyway, why don't we just go the full distance, anesthetize, do a keratectomy on both, and then, reduce our chance of them having to experience this again. And those are times where, I'd make the argument for that. On the contrary, I guess, if you have a dog that is a very good dog that could sit very well, perhaps maybe an older patient or something that's, not really a great, might have some comorbidities that make it not a great sedation or anesthetic. And that's when I'd be leaning more to, pushing more for those other procedures, or maybe saying, look, I think the keratectomy is not even an option at all. Is that similar to how you sort of go?
Oh, mate, yeah. You got to weigh up patient factors, those the first and foremost, and then client factors probably come secondary to that. But yeah, I'm with you. In a case where the general anesthetic is, as low risk as it can be, and especially if there's some patient factors of how spirited or shy or non-anesthetic procedure difficult, even giving the client like as close to a defined end date as possible, where you're like, by the time you've seen me, often the dogs have the ulcer for 3 months, the dog's over it, the owners are over it. Anytime the owner comes near the dog with a bottle of eye meds, the dog's hiding under the bed or something, you're like, listen, I can't, there's no promises in medicine, but I can give you as close to a guarantee that in 2 weeks, this is all over if we do the keratectomy. They're the ones where the clients are probably like, yeah, let's do it. And yeah, you always have to weigh up the anesthetic risk. That's the biggest con. And, of course, because it's a larger procedure, you involve a general anesthetic, recovery financially as well. Like that's the world we live in. That's a factor as well. Yeah. Absolutely.
The only other point I'll bring up there is, and this was a more recent paper that I'm not actually sure if, I don't even know if I can talk about this because I'm not sure if this is something that I know someone who reviewed the paper or, no, this was published.
I was going to say, it sounds very scandalous, mate. Hot off the press. Yeah, oh my word. Paulie with the insider knowledge.
The insider knowledge, no. There's basically a paper out there that's just very recently come out that talks about success rate from, ulcer healing in terms of the diamond burr. I think it was the diamond burr debridement procedure, but basically they found a slightly reduced success rate in French bulldogs specifically, I believe it was. Yeah. And so in those clients, I'll quote that lower number. And sometimes, as Ben said, if they're the type of client that's had their dog's had an ulcer for 3 months and they're over it, and it's you're telling them 75% instead of 85%, sometimes that'll tip them over the line. The other, sort of weird scenarios that I've seen, not weird scenarios, but real life scenarios that I've seen is, clients coming in and they're like, I'm flying to, wherever it is in 3 weeks' time, and
I had one of those 2 weeks ago. Yeah.
3 months.
We got a holiday to Hawaii booked in 11 days, and I'm like, I can't make any promises, but I can give it a rip up there to get this done in 11 days for you. Yeah.
So I think we'll briefly touch on aftercare. Ben, do you want to sort of run through just generally what we do on aftercare, absolutely. And then we might wrap up?
Yeah, that sounds great, man. Yeah, aftercare for any of the above procedures is really similar. As Paul touched on, probably duration of aftercare is the big difference. But yeah, typically I'm sending these guys home with a prophylactic antibiotics topically, some analgesia by mouth, a topical, a contact lens will be placed both for patient comfort, and some studies have shown it mildly increases healing time as well. And that's about it. Like I have if there's underlying issues as well, like adding an ocular lubricant would be helpful if they had borderline tear production or something. But yeah, otherwise that's all I'm doing for these. Are you doing anything too different?
Pretty much the same. I think you know, the only thing I'd mention to that, like all ulcers, is, you know, Elizabethan collar, the cone of shame. And then, you know, I think there are certain breeds, and again, I think there's a recent paper on this, but certain breeds that and certain individuals even that I see a really pronounced sort of inflammatory response afterwards, a really pronounced vascular response after either of the procedures. And again, the classic that I see clinically is sort of the brachycephalic breeds. And in those dogs, once the ulcer has healed completely and epithelialized, you know, I start to look at options in terms of trying to get some of those blood vessels to go away. And in, you know, some cases that might be a topical anti-inflammatory. In other cases that might be something a bit milder, depending on how nervous I am. And you know, probably the mildest that you can use for those.
Oh, sorry. Just to clarify, is that once the ulcer's healed, or is this?
That's once the ulcer's completely healed. Yeah, for me.
Yeah.
And the mildest thing I use is something like a hyaluronic acid. You know what I mean? Base drop. Yeah. So that's probably the easiest, safest thing if you're unsure. You know, and you can. I always say to clients, you know, that might be for months, and it's sort of like a cut healing on the skin. You know, the cut might be healed, but there might be somewhat of a scar there. And on the cornea, that scar, well, scar implies, you know, it's permanent, but that might be, you know, blood vessels that we're seeing, that might be opacity, that might be pigment. And so, you know, once the ulcer's completely healed, I want to work at getting that away. There are some cases as well when I start to see pigment getting laid down after the ulcer's healed. And again, more so the brachycephalic breeds. And in those cases, I might reach for something, you know, like tacrolimus or cyclosporin, or even, you know, some soft corneal cryotherapy way down the line. But often I find
for pigment, if they're heavily pigmented and stuff. Yeah, for sure. Yeah.
Anything you'd add to that, or is that all pretty good?
No, mate, I think that's about it. I mean, without trying to best you for hot off the press and confidential stuff, but I recently reviewed a paper looking at, so who knows, maybe it'll be coming out shortly, but interestingly, just to your point of brachycephalic dogs with more scarring, a paper that was excellent. I've no idea who the author was because obviously it's all anonymous and stuff, but there's certainly some works coming out that imply that maybe, you know, we'll have something more solid soon to report regarding that. But yeah, people have started to look at the opacity of corneas after these procedures, and yeah, to no surprise, these brachycephalic dogs seem to have a harder time clearing their cornea afterwards. So
yeah, well, there you go. Yeah. All right. Well, Ben, enjoy the Super Bowl today. I'm now going to be hoping for the New England Patriots to win. So, you know, you've got me in on this syndicate, so to speak.
Wonderful.
With
My
no money
advice
down,
to you, that's right. My advice, mate, look up who the quarterback is, look up what college he went to, and then just claim some vague connection to that college, and everyone will think you're the authority in the room. In Australia, that level of knowledge is all you need. You'd have to look it up, mate. I don't know. Yeah,
you don't know.
Yeah, I don't know.
In America, you're not even trying to have the knowledge. I was at the park yesterday, actually at the dog park, and this British guy came up to me wearing a Seattle Seahawks jersey, and he was talking to me about like how excited he was for the Super Bowl tomorrow, which I found I found the whole thing confusing, to be honest, because he's very British. I was like, "Oh, did you live in Seattle?" No, I didn't. Okay. Anyway,
like, you know that the team they're up against they're from New England.
Is New England.
Yeah, you think it'd be going for those guys, right?
But yeah, he started talking to me about. He's like, "Oh, mate, you've got to get into you know, NFL," and I was like, "Oh, maybe, like, yeah, it'd be interesting." I just don't know. I don't know the rules, and you know, he basically like, "Oh." I'll talk to you about them. And then he started telling me, you know, all of the very fundamental stuff that if you've played one session of Madden NFL on your Xbox, you know. And I'm like, yeah.
I get it, mate. Like you press X when they're running to the sideline. I get it. Yeah. I get
it. Yeah. All right. On that, we'll sign out. Have a lovely NFL Monday for everyone in Australia, and an NFL Sunday, a Super Bowl Sunday. Sorry, NFL. Yeah, NFL.
Exactly.
Yeah, we'll see you guys next week.
Okay. Catch you, man. Bye.